call for rights all the time, yelling, you gotta stop coercing and forcing people into treatment, but not come up with alternatives. So I'm not sure if you're familiar with Jim Godstein's psych rights. What I proposed to this group was, a few years ago, alternatives, he proposed this triangle that's really cool. Is you have rights and legal and advocacy. Up here you have actual alternatives, and then over here you have campaigns to move the public's perception of what psychiatric diagnosis and labels are. And so I kind of presented that here. We got this respite house. We have our advocacy, which is really a reasonable accommodation for people to be afforded an advocate to go to court with them, to treatment team meetings, any engagement that they feel they may need support with. And sometimes they just come to us and they go right to respite. Then we started adding acupuncture, Reiki, things that were really self-help groups, things that were really different in trainings. And now we're taking that campaign to the community. We've had a couple good successful newspaper articles about what we're doing in the community with our respite house. Some big fundraisers. We have a boat cruise coming up in May, and we're really trying to change that prejudice and discrimination, so that it becomes a more community focused support. We get funding from multiple places. All our money comes down from the state of New York and through the counties, and then we get a particular budget for the population of people that you service and support. And then we have the closings in the 80s, the closings of psychiatric institutions, some of them. We receive community reinvestment dollars, so a portion of that is part of our respite funding. And then we've been able to raise about $25,000 independent from the community. We're trying to make it a campaign in the community so they understand that this is something that can be utilized as a community as a whole, not just portioned off as just mental health. So our funding stream, we've been able to push to at least be operational 5 days a week, 24 hours a day. Our goal is by next year to be 7 days a week, 24, and we're just flat open. But you have to work with what you have. So a woman came here, and of course I have to keep anonymity, but she came and said, I'm fearful that I'm going to get locked up. So we met with her peer advocates, and she says, I know you have the respite program. I need to get there. So we don't do intakes, we do dialogues. Tell us what's going on, what can we do to help? Do you think respite is actually what you need as support? Tell us why, and what would this be like? What would it divert you from having to deal with? And she shared, and through the advocacy and the respite piece, we were able, over a 4-day period, she went into respite. Through the advocacy piece, we were able to find out she had what's called a mental hygiene pickup order here in New York State. We call them mental hygiene arrest warrants. And she was able to divert that because an advocate worked with her to call the county, find out if they have one. If there was one, we can negotiate that with them. And at the same time, she's in a safe place, which is the respite house where she feels most comfortable and safe. And through that, we were able to not have a pickup order done. And this person is now, after 4 days, was able to get a 30-day stay at an apartment building through another community resource, and now is actively finding a place in the community to live. We keep things really low lit. It's we don't want things too stimulating. We do one TV and one radio in each room because people have told us, I don't like TV. So we try to keep it accommodating for persons. It's really small, really basic. We just got a local bare bones. This mattress company is going to give us double because we found these somewhat institutional. But money is of the essence, and we've been really seeking for communities' donations to help us. So we're hoping we're going to get a double bed for both rooms. We try to, we have closets. We try to, when people come, we try to have it as comfortable as possible. These boxes, it's total their control. They pick their key. If people use medications, obviously we have to have them keep them in their own secure way. So we give them lockbox and key to the house, and they can set up. Most people throw their stuff around and make it like it's their home. At the food bank, we go there about once a month, stock up, keep it in the freezer, and then a little freezer in the fridge here, just so people can. We have multi things of food, but we have to do a lot of canned stuff, so it's here because it's so unpredictable. Frozen stuff. But the other process we've been using is we get Price Chopper cards, which is our local, or Hannaford, and if people want, they can take $20 card and go over and pick out what they want. And that sometimes people like that; they want to get out and about, and so they'll go shop.
Can they order out?
Yep. Oh yeah, people. Oh yeah, that's a big thing. Breaking bread and eating together. We see there's a mix of people like to cook together, which is bonding between the support person, and the person who's here using the support, or they just want to chill and order pizza. You can watch chicken wings and pizza. It happens a lot, and we get the receipts. And that's what a person chooses. So we try not to have as much processed, food. But some people like junk food, and that's soothing. I know I like my chicken wings.
I have a question. Yep. Who does the cleaning?
The staff. And the person who's here. We find there's... What's cool is, and what we learned through the intentional peer support thing was this, they call it co-supervision. We don't use the word here, but, core support, co-support, is there's a sharing in everything that happens here. And from chilling out back and smoking a cigarette, and to cleaning up and doing laundry and moving things around. It's usually the two people together. But there are times, person doesn't want to do anything, nobody has to do anything. And the staff, obviously, that's one of our things, is we have to keep things neat. My biggest influences from being institutionalized personally, one thing I'm very sensitive to is how we ask people to contribute versus having to have a chore list using the support, because the days of slave labor in institutions and you gotta pick up cigarette butts and do laundry and scrub the floors. So anything institutional based, we've tried to X out of here as much as possible that it can be. I mean, there's obviously home living is, you got to do your laundry, you got to do your laundry. Our staff isn't going to do a guest's laundry. One thing we set up was a person's phone in each room so that they could use the phone. It's still on one line. We have a second line that's being added here because we're creating a support line for the community, which some people call them warm lines. We call it a support line because we want people to call. Is the support needed advocacy? Is the support needed self-help, mutual support groups? Is it the respite house? Is it just a chat? Is it advocacy? So we want our main piece to be anybody can contact us on a 1-800 number any time of the day. That'll run in, the phone line will run into this, but be a separate line for people. So we can only get 2 people in to use the respite house. Our hope is through the support line, at least we can divert some more crisis through at least good conversations with people or resourcing them to the places they need. But the state can easily say to anybody, well, you got 2 empty beds today, and my always come back is, well, why do you got 40 empty beds at the psychiatric institution? So this is a lot cheaper, $200 a day. If you have to equate money to $1,200 or $1,400 a day for a hospital. $500 when you walk through the door at the hospital. I tell them it's a conversation with us. We've been really trying to sell that to them, and our local behavioral health unit has been supportive. And we've started to get, as we got out there, they would call us and say, listen, we have a person that might use your support. Well, of course, if any of your providers, this isn't to say negative, usually the conversation is they want to talk to us. We say we need to speak directly to the person. And that was a change in this community. We said, listen, we appreciate the referral, if that's what you want to call it. We need to talk to the person directly, find out what's going on, not through your words, his words. And that's worked out great, and they've been supportive. The change of climate in our community we're seeing as we talk more about respite, or the people who used it talk more about it. And the only problem is you need more rooms, you need
So
more bedrooms.
It's sliding scale in terms of what people pay for this, or is it?
Pay a thing because it's through our budget, our program, and our support is funded by those multiple pieces. So it's totally free. You know, I'm a human rights guy. I believe we should all have fair housing. They have mental health housing, substance abuse housing, and they have crisis beds. Yeah. So they don't actually have crisis houses, but they have crisis beds in those mini institutions, I call them. And what we still, you know, we're separate from that. And what we find is people don't want to end up in any of those kind of places. And our goal is to offer a home-like environment where you can walk out the back deck. It's messy from the winter, but you'll see there's 2 chairs and a table, and we have a Lowe's. We have a good relationship with Lowe's, but they're giving us all the garden stuff to have our own garden. Our landlord said it's okay to have a garden, you know, the idea is to be different from those. Very good relationship with the county, both counties, Washington and Warren counties. I mean, if people are having complaints or they want an advocate, as soon as they say advocacy, they're on. You know, they're linked with us. So if they say, it might be too late sometimes, but they say at the hospital, I don't want this medication, it doesn't work, and you know, the person says, I want a lawyer. At least they have the avenue to contact us, and we can get in. We have advocates who can go inside and start working with the person. You know, we don't have the ability to free people, but we can go to court if it's a medication over objection hearing, retention hearings, moving you to a state institution. So our advocates, we're trying to build. This is a group we'll have probably hopefully about 30 peer advocates that can be voluntarily prepared to help people, because they don't want to pay us, that's for sure. They don't want to pay people to help in that capacity. But so the idea for us is to have that, maybe move to a 4-bedroom respite house instead of just 2 in the future, so that we can help you know, persons who are looking not to go to the hospital. You know, we do have a lot of people who also come to the respite house who have been coming off psychotropic medications / drugs, who are as well maybe a change, and so they're afraid. We hear this a lot. They're afraid in the change or coming off that they want some kind of support and not have to depend on the hospital, so they can come to the respite house. You know, some people are just, you know, no home, and that's a tough one because we don't want to reciprocate housing. We're short-term crisis diversion is what you know, our main goal is, but we have a lot of family disputes where people will call us, say, I gotta get out of the house. My husband and wife said they're gonna call the cops on me, or you know, it's just we have family domestic situations where sometimes people just call and say, I want a break. You know, it's hard because we only have 2 rooms, 2 bedrooms, and sometimes a week ago we had 8 calls from Thursday to Sunday, and we can only fit 2 people in. You know, and we try to say, listen, when you come in, set a plan up. So you don't have to. We don't want this to be a reoccurring visit. We want you to connect, move on to where you need to move on to. But you know, we find people, we don't want to use it as a crutch. We really want them to come in, use the support the best they can, and really connect to the other resources we have and the other resources you want.
Rise together, we rise together, we rise together, we rise together, we rise together, we